Hello, everyone. Thank you for joining us today. I'm Carla Silverman, and I'm honored to welcome you to today's panel, Innovative Medicaid Strategies to Enhance the Behavioral Health Workforce. Strengthening behavioral health services is a top priority for Medicaid agencies across the country. At the Center for Healthcare Strategies, we have spent decades collaborating with state Medicaid programs, managed care organizations, and providers to find more effective ways to increase access to high-quality, person-centered behavioral health across a continuum of settings. Today, we're excited to hear directly from three mental health and substance use care experts in the Medicaid space. They're leading innovative efforts to address the behavioral health workforce shortage, and they'll share what's working, what's challenging, and what others can learn from their experiences. Next slide, please. Before we begin and I introduce our panel, I'll provide a brief background on the Center for Healthcare Strategies. CHCS is a national nonprofit that works to strengthen healthcare services to ensure better and more equitable outcomes for people served by Medicaid, particularly those with complex health and social needs. We partner with state and federal agencies, health plans, providers, community-based organizations, and consumers to address the obstacles that stand in the way of better care and improved outcomes. Our work advances more effective models for care delivery, more efficient policy and program design, and ultimately more equitable care. Next slide, please. So let's dive into today's agenda. I'll start with a brief overview to set the stage, covering key background on Medicaid and behavioral health workforce issues. Then I'll introduce our fantastic panel. We'll spend most of our time hearing directly from them, both about the challenges they see and the innovative strategies that are being used to improve behavioral health care and address the workforce shortage. We'll leave some time at the end for audience questions. Please feel free to drop your questions into the Q&A tab at the bottom of your screen at any time during the event. We may not get to all of them today, but your input will help shape future conversations. Next slide, please. Medicaid plays a critical role in financing our behavioral health system. It is the largest payer of behavioral health services in the country and thus has an opportunity to drive system change across a broad continuum of mental health and substance use disorder treatment. We know Medicaid serves a disproportionately higher share of members with behavioral health needs, and those needs are often complicated by complex physical health and social needs. Next slide, please. But despite a number of advances over the last decade and greater public awareness of behavioral health issues since the COVID-19 pandemic, our behavioral health system is still significantly under-resourced when compared to the need for services. Supply cannot meet demand. Across the healthcare sector, not only within Medicaid, only half of adults with mental illness and fewer than 1 in 4 adults with substance use disorder receive treatment for their conditions. Notably, these gaps are not evenly distributed. While the behavioral health provider shortage is national, rural and other underserved communities experience this shortage most acutely. More than half of US counties have no practicing psychiatrists. And certain populations are also disproportionately impacted by the limited amount of behavioral health providers. For example, there is a shortage of behavioral health providers for children and adolescents. The child and adolescent mental health crisis is everywhere around us, and today suicide is the second leading cause of death among youth aged 10 to 24. Additionally, 1 in 5 pregnant and postpartum people experiences a mental health condition, and suicide and overdose account for 20% of postpartum deaths today. This is another critical population that needs better access to behavioral health services. Next slide, please. The behavioral health workforce shortage is driven by multiple interrelated issues. This is particularly true in underserved areas where staffing shortages are more pronounced. While there is no one cause, key factors driving the shortage of behavioral health providers include low reimbursement rates for those covered by Medicaid, making it difficult for behavioral health providers to financially stay afloat. high caseloads and administrative burden, high rates of burnout, and providers reporting feeling unsupported, expensive and lengthy training and licensing processes, and in many cases, there are few opportunities for career advancement, driving experienced and skilled behavioral health professionals to leave the field. Next slide, please. We know that providing behavioral health care is difficult, taxing work. Burnout is a significant issue, particularly for those caring for Medicaid and other underserved populations. Many providers report needing more support to manage patients with high acuity and complex conditions, and that the caseloads they are asked to carry are often excessive and not sustainable. Yet, despite challenges created by the workforce shortage, a majority of those in the behavioral health field report remaining passionate about and fulfilled by their work. Next slide, please. Now I have the distinct pleasure of introducing our distinguished panelists. We have with us today Emily Eibel, Director of Behavioral Health Strategy and Policy at Mass Health, Elizabeth Morrison, creator and founder of the Lay Counselor Academy, and Jane Zhu, Associate Professor of Medicine, Division of General Internal Medicine and Geriatrics, the School of Medicine at Oregon Health and Science University. Next slide, please. And just a reminder, if you have questions during the session, you can put them in the Q&A box at the bottom of your screen. Oh, so let's go back a minute. I think we could probably take the slides down, and great. And Emily and Elizabeth, you guys can come on camera. Wonderful. So I'd love to start by hearing from each of you about your work and how you think about addressing the behavioral health workforce shortage, particularly for the Medicaid population. What are the key challenges that you're seeking to address? And Jane, I'm going to start with you. I know that your research recently showcased in a Milbank article has compared state and provider strategies to address the behavioral health workforce shortage. And I would just love to hear about some of the approaches that are being used today.
Sure. Thanks, Carla, for a great overview, and thank you to CHCS for holding this panel. So I am a primary care physician. I am not doing the hard work of, being on the front lines of implementing policy, but I do research on how states and Medicaid managed care plans are responding to the behavioral health workforce crisis in Medicaid. And so Carla mentioned a couple of articles that we've written that really do a scope to look at the levers that states are currently using to recruit, retain, and support the workforce. And we've found four main levers. The main one has been implementing increased reimbursement rates and provider wages. So Kaiser Family Foundation, just a shout out to them. They are a great resource in terms of understanding what's going on at the states, at the state level. And they surveyed states recently. And in the past 3 years, close to 30 states have implemented or are considering implementing rate increases for behavioral health services in Medicaid. Some of these obviously are cost of living increases because in Medicaid, there's no statutory mechanism to adjust reimbursement for inflation or for cost of living, but some of the increases have actually been quite broad in scope and substantial in magnitude. North Carolina, for example, instituted their first broad-based reimbursement rate increases for behavioral health services, the first in a decade, by appropriating $220 million in recurring funds. And they implemented that in 2023. As an example of the rate, the scope of the rate increase, they increased inpatient psychiatric care from under $500 a day to nearly $900 a day. So that's a 30% increase. New Mexico has raised behavioral health rates to 120% of Medicare. Iowa increased their provider rates for substance use disorder by almost 100%. A lot of these have been substantial and are worth watching. Some of these investments are supported by federal pandemic relief funds. So it's unclear how sustainable or how long-term these changes are going to last. But some of them have been from state general fund appropriations. So there is a lot of heterogeneity in terms of what's been implemented, what we can evaluate, what we can monitor. What we don't know yet is impact, whether these increases will really bring new clinicians into the fold or they're going to slow attrition amongst those already serving Medicaid populations. Just very quickly, I'll overview a few other levers. One is workforce pipeline programs. These have been in place for a really long time. A lot of states are doubling down on scholarships, training, loan forgiveness initiatives, often in partnership with federal agencies like HRSA. One standout example that we wrote about was Nebraska's Behavioral Health Education Center. This is a center that's provided sustained funding for training across educational levels since 2009. And the program reports that they increased their state's behavioral health workforce by about 40% over a 15-year duration, which is a rare case of long-term measurable impact. However, I think there's a lot of these efforts are either new or they're unproven. So retention after the service commitments in these programs remain low, and clinicians who train in underserved areas often leave after fulfilling their obligations because of the burdens that you've already talked about. A third lever is reducing administrative burden, which in my view is one of the most under-recognized drivers of workforce loss. In Medicaid, clinicians are describing credentialing delays, prior authorization, unpredictable or delayed or denied payments as reasons that they often drop out of Medicaid. And then if you compound this over many MCOs, other payer plans that clinicians accepting insurance have to work with, you can see that these efforts get out of hand very quickly. And behavioral health providers are often solo or small group practices that don't have excess capacity to deal with these requests very well. And so many states are thinking about or engaging in efforts to streamline documentation. They're standardizing credentialing across MCOs at the state level, or they're establishing prompt payment policies. New York and Illinois, amongst other states, have actually invested in technical assistance infrastructure. So these are centers that help smaller behavioral health agencies and community providers with billing and electronic health record support. And so these programs are really designed to lower learning costs, reduce administrative friction, but I would say the aggregate evidence on their effectiveness is really still unclear. It's still emerging. And then finally, the fourth lever that we've looked at have been around efforts to expand who can deliver and bill for care. Many states have broadened their workforce definitions in order to try to stretch capacity. So about 40 states now reimburse for peer or family support specialists, 24 reimburse services delivered by trainees or license eligible clinicians, so not waiting until the licenses actually come through. And then obviously telehealth has been really a big change in terms of telehealth coverage mandates, payment parity in some states. Most states have now made permanent coverage for audio-only telehealth a mandate, and they've joined interstate licensing compacts for psychotherapists, as an example. But the full benefits of telehealth are still unclear, and they've been really limited by broadband gaps and uneven uptake, amongst other challenges. So I'll stop there. Just an overview of what states are trying to do. Most of these initiatives are time limited, they're under evaluated, they can be fairly modest in scope. And I just want to point out they're really treating the symptoms without necessarily addressing fully the underlying structure of how behavioral health care is financed and delivered, which is a historical concern. But I think there's a lot of opportunity there in terms of state laboratories, what states are doing to evaluate and adopt what works, maybe move away from what doesn't work, and to really share best practices across states.
Great, thank you so much. And you actually set me up very perfectly to turn to Emily to talk about a specific state, Massachusetts. Emily, can you talk to us a little bit about the Massachusetts Behavioral Health Roadmap and how that seeks to address workforce barriers in the behavioral health space.
Yeah, absolutely. And I feel like Jane laid it out very well. So Massachusetts Medicaid Agency, Mass Health, in partnership with other agencies in the Executive Office of Health and Human Services in Massachusetts, has really tried to take a multi-pronged approach to supporting the Medicaid serving behavioral health workforce. I categorize it into three categories. One is workforce pipeline and recruitment. Second is training and development, and third is supportive programs and payment models. So I'll briefly highlight a few of our initiatives in those spaces that we've focused on the last several years. So the first, workforce pipeline and recruitment, Massachusetts has invested significantly in loan repayment programs, and we have currently over 4,500 participants who are awarded $220 million across programs focusing primarily on behavioral health providers. And that kind of provider set is wide ranging, ranging from psychiatrists to recovery coaches in terms of eligible provider types. And also in the bucket of workforce pipeline and recruitment, we've had some longstanding targeted programs really focused on service areas where recruitment is especially challenging, such as youth, home and community-based behavioral health services. So for example, in that space, we partner with local universities to offer a social work elective course that introduces students to these in-home services and kind of this career pathway they might not otherwise know exists. And also support fellowships for master level interns in these in-home services, again, to introduce them to the services. The second bucket I'll highlight is training and development. And so as part of our behavioral health roadmap, that is a major state initiative, we launched a behavioral health training clearinghouse, which really serves as a centralized repository for training for select behavioral health providers, offering both asynchronous and live trainings to support that workforce. And over the last year or so, we've been able to expand the types of providers that have access and really build out the training offerings responsive to our providers' feedback in terms of what would be most helpful in topics such as, substance use disorder competencies and a wide range of topics. In addition to kind of this broad-based training support, we have supported smaller, targeted, intensive cohort-based trainings that combine kind of a content orientation, but also a wraparound learning community and coaching supports over a longer time horizon to really make sure that our providers not only are getting the content, but have spaces to practice and apply that content, and have had some really good feedback on the power of those kind of more intensive training models. The last bucket I'll highlight is supportive programs and payment models. So we've focused a lot in the last several years in thinking about how do we change our requirements and our payment model designs to support flexible team-based care and services delivered by a broad range of clinician types. So what that's looked like for us is we've introduced a series of bundled payments. So for example, we have a daily bundled rate for our community behavioral health centers and our behavioral health urgent care clinics that provides a single payment for all services received by a member in that clinic on a day, regardless of clinician type who provides those services. We also have other bundles like weekly opioid treatment program and a few others. We've also introduced case rates for two of our peer services, so recovery coaching and certified peer specialists, with the goal of kind of having predictable revenue streams for those peer providers, acknowledging that a lot of the members they work with need to have their kind of support levels titrate from day to day, week to week, but a more predictable revenue stream is supportive of those peer providers. And the last area in this section I'll highlight is we have a primary care subcapitation program where we pay a capitated payment to our primary care providers. It's a per member per month payment. And as part of that, there is a tiered component where practices are paid higher per member per month rates if they meet certain requirements. And a core part of those requirements are behavioral health and substance use disorder capacity and capabilities within the primary care setting. So those are just a few examples of different models. We have a number currently in place and in the works to support our workforce.
Thank you so much. I have follow-up questions, but we'll circle back, I think, later on in the webinar. So Elizabeth, I want to turn to you and ask if you could talk about your model and how it seeks to expand the behavioral health skill set to a broader lay workforce. So would just love to hear about how that came about and your approach to that.
Yeah, sure. I feel like I have to just say first that I was trying to be helpful with the live questions and ended up like sending the wrong link to Jane's paper like it 2 different times. So I'm really sorry about that for those folks who asked the question.
We'll fix it.
Just wanted to alert CHCS that like I didn't trying to be helpful and wasn't super helpful. I also just want to say thank you so much to CHCS for asking us to be on this panel, for hosting this webinar, but more broadly, just for fighting the good fight for equitable, high quality care for folks who are publicly insured or uninsured. And also, even though we can't see you guys, like we can't see the 400 people who are here, I just want to say that like the only relief I get in the world right now, in the state of the world, the state of our country, is being around people who have similar values, who are just doing the work. And I know that's all of you. So even though I can't see you, I just want to say like I feel you and I'm glad to be here with you. And I'm a psychologist and an LCSW and an addictions counselor. And I wish like I had read Jane's piece. Like I wish I'd known that there was a group of researchers just looking at stuff that burned us out. Because I left my FQHC after I was like putting down my, putting my kids to bed and opening my computer until midnight doing my EHR. The documentation burden is real. So just hearing that, and also kind of wished I lived in Massachusetts where Emily is, when with all of that provider support that they're doing there. So the support for providers that both of you guys are doing in different ways is super meaningful. So I was just telling CHCS Carla, who I've known for a long time, that I'm from Alaska. And I was born there, I was raised there. Alaska is almost 700,000 square miles. It's like 3 times the size of Texas. Sorry, Texas folks. There's like a beef between the 2 states. There's like bumper stickers in Alaska that say, "Isn't Texas cute?" Like, there's like a lot of, but my daughter was delivered by a lay midwife, and in Alaska, lay midwives, you don't you don't have to have anything. You don't have to have any schooling, you don't have to, you just have to learn to deliver babies from another midwife. And that's because, we need people to deliver babies in villages where there's no road systems. And, it's the lowest density population state, right? So you need people who can do this work. And that's why we started the Lay Counselor Academy. We call it the Lay Counselor Academy after lay midwives in Alaska, because we know that the qualities that make up effective therapists are not dependent on graduate school and licensing. That the research is quite clear that what is therapeutic and the treatment that is provided in therapy, that is a first-line treatment for every mental health condition, which people cannot get access to this treatment right now. Of course, that's why we're all in this webinar talking about this. We know that what drives those outcomes is the therapeutic alliance. And the therapeutic alliance is this complex mix of warmth and friendliness and humility and self-reflection and interpersonal skills. And so we think we need, like, my team and I believe that we need another way to develop mental health counselors outside of 6 years minimum of schooling, and a really long licensing process. And there's many other countries in the world that have done this. India for decades has been using lay counselors, folks that are trained outside of academia, that practice alongside folks who kind of are traditionally trained like myself. And the research is quite compelling. India, Ghana, Ecuador, South Africa,
The research is really clear in these countries that lay counselors can deliver care that's as effective as licensed clinicians. And we actually have data now in the US that shows us that too. And I see it on our own team. We have licensed people on our team. We have lay counselors on our team. We collect data from the patients that we see, and we see the same outcomes. That doesn't mean that anyone can do mental health counseling. So I hope nobody, like all of the other clinicians, like please know that that isn't what I'm saying. Mental health counseling is deeply skilled work, and not everyone can do it. All we're saying is that the license and the degree is not the thing that guarantees skill, number one. And that there are people who don't have that do have the innate characteristics, the natural skill, and can be supported to provide mental health treatment. So in the Lay Counselor Academy, we started it 3 years ago, and most of the people that come through it are CHWs, peer counselors, SUD counselors, case managers, promotoras, health navigators. They're people in our communities who are already in contact with the very patients and clients that we want to provide mental health care to. They are already talking to them. They are already in trusting relationships. But for most of these positions, mental health counseling is explicitly carved out of what they do. So CHWs, like, they don't get mental health counseling training. They're not supposed to be providing treatment for anxiety and depression. It's carved out. For SUD counselors, even though they treat one of the most complex conditions, behavioral health conditions, mental health counseling is explicitly carved out of that too. Same with promotoras, same with health, case managers. They're supposed to recognize and refer. It's like a mental health a mental health first aid, but there's no place to refer. And they're already talking to people who already trust them. So we give them an intensive dose of mental health counseling, evidence-based mental health counseling. We do therapeutic alliance, we do CBT, we do behavioral activation, we do motivational interviewing, therapeutic alliance again, empathy as treatment. We talk about how to protect themselves from vicarious trauma, which ideally they would have gotten before they started working with people. But I think we're still in denial that they're hearing all kinds of, trauma disclosures, our CHWs and promotoras in the community. And we've trained about 1,000 people. And we've had really good outcomes, which I can talk a little bit more about later. We just had the California Healthcare Foundation just finished a study on graduates of the Lay Counselor Academy, and it's really exciting and fun for us. So I'll stop there.
Thank you so much, Elizabeth. Yes, so many thoughts and reactions, but I'm gonna keep us moving. And it's so wonderful that you have your academy and your approach, and that it's showing these amazing results. So I'm gonna ask each of you if you could, pick what you think a state should focus on in terms of a priority for strengthening their behavioral health workforce. What would that be? And I'm going to ask you to maybe stay to around 2 minutes on the answers here. So Jane or Emily, who wants to start here? Go ahead, Jane.
Sure, I can give this a go. So I just want to state a couple of things. I think states need to be aware that there are certain segments of the behavioral health workforce that will not take care of Medicaid patients, regardless of how high the reimbursement rates are or how smooth the administrative processes are. And second, this is a related point, Medicaid services are, and we see this in the claims data and in our research, they are disproportionately provided by a core set of providers, often community behavioral health providers, really mission-oriented folks. And so the departure or exit of one of these providers can really have an outsized effect. So I think that in an ideal world, everything is important, everything is great. In a realistic world with budget cuts and restraints and other limitations, I think, in my opinion, the key thing that states can focus on is to strengthen and bolster those core providers. And so one promising lever that I personally would love to study more, I think should be expanded, are targeted reimbursement increases. So this would work in budget constrained settings and be flexibly applied to places of highest need. So rural geographies, core providers, crisis transition services, or the sort of clinicians that Emily had brought up in her state, like adolescent, child psychiatrists, and other providers. States can't directly set rates because most Medicaid behavioral health care now is delivered through managed care, but they can use what are called directed payments to tell MCOs how to pay providers. So they can add on a per visit add-on or a Medicaid load adjustment. One example of this is in Oregon, my state, where we recently implemented a 30%, on average, 30% rate increase for behavioral health services, with higher adjustments for Medicaid heavy agencies. So providers that actually serve a higher share of Medicaid enrollees get paid more. And there's additional state directed payments for people who have cultural, linguistic expertise. And so this mechanism gives states more control over reimbursement in a managed care environment, which is more and more the reality, and ensures that the payment increases, the funding actually reaches the frontline providers rather than get, sort of diluted in the plan finances. And so I think payment policy is very, very promising. It's very powerful, but it can be used strategically, not as a blunt instrument, but as a way to really stabilize the system and reinforce other workforce investments at the same time.
Thank you so much. Yeah, I love that strategic payment strategy to particular providers that are needed. Emily, would love to turn to you and hear your thoughts about what you think a state should prioritize in terms of supporting their behavioral health workforce.
Yeah, I mean, I think if you have the resources, a multi-pronged approach, as I mentioned, is helpful and powerful. But I think also, we've been really thinking about how do we support the right care to the right member at the right time. And I think that's really about thinking about your service continuum and where is there capacity in that, where are there providers that are focused more on Medicaid populations, and also thinking about, matching the workforce to the needs of the members. So we support, a wide range of clinician types, peers, unlicensed, licensed, MD level, and really the focus is how do we connect those to the right members to make sure that we're kind of helping to match those resources. And I think in that, when you think about a service continuum, thinking about matching, kind of to Jane's point, payment levels to requirements. So, we have providers like our community behavioral health centers that are our front door. They provide crisis services, they provide urgent access, after hours, additional staffing, et cetera, and matching those enhanced requirements with enhanced payment, and to make sure that we're adequately resourcing those providers that have leaned into serving our population and meeting the needs of various types of acuity and complexity of that population. So I think kind of looking at a system-based approach and really thinking at a state level, where are gaps to support the right care to the right member at the right time, and targeting that way.
Thanks, Emily. I want to circle back with a follow-up question in a moment, but I'm going to ask Elizabeth to, what do you think a state should be focusing on or prioritizing if you had to choose one thing?
Well, we have a lot of people who ask us, don't you want lay counselors to be billable? And in our current fee-for-service system, that is the majority of how care providers are paid, we wouldn't want them to be billable. Because documentation burden is one of the things that is driving people out of the workforce, as Jane has found, and as like many of us on this webinar have lived. So 80% right now of licensed mental health clinicians type during a session, even though the treatment in therapy that works is the listening. And you can't listen and type at the same time, but that typing during sessions is driven by that documentation burden. So we would not want to see that happen to folks who were our lay counselors. So as opposed to thinking about fee-for-service billing, I think more what Emily was talking about is the bundled payments, the capitation, the value-based payments, the alternative payment methodologies, like getting out of the tyranny of the fee-for-service, which will always be tied to a credential or licensure. And I think gives a lot of us position fatigue. Like in California, they just rolled out certified wellness coaches, and everyone's like, well, what is that? Is that the same as a CHW? Is it different than a peer? Is it, there's sort of position fatigue. And I certified wellness coaches in California also have mental health counseling carved out of the scope. So those folks also can only recognize and refer. So I think that really focusing on the capitation and the value-based payments allows so much flexibility in the care that is provided to somebody, and allows for people who don't have licenses and degrees, who are highly skilled lay counselors. Maybe they're CHWs with lay counseling skills, maybe they're SUD counselors with lay counseling skills, to be able to be paid as part of that bundled payment.
Yeah, thank you so much. This is actually a really good setup for something that I wanna talk about more about payment, but I'm gonna go a little off script here and just focus on something that I think is so interesting and important. And that is, can one of you talk about how an alternative payment, or a bundled payment or a daily rate or a monthly rate supports the delivery of team-based care, and why we should care about that, why that helps us in terms of broadening and supporting our behavioral health workforce.
Maybe I can start and then pass it off, since we've been focused on this. I think that, there's a few elements of something like a bundled payment that is supportive. One, the getting away from documenting every single 15-minute unit, and to Elizabeth's point, kind of the hyper focus on what is billable, productivity, documentation, I think really frees up some time to actually talk to your colleagues and kind of think about cases, do things that are less, make a phone call to the school, do things that are less likely to be traditionally billable in those units. And also, I think, allows better matching of the clinician level that is most appropriate to member need. So there isn't a driving of, okay, what is the margin of this provider type with this fee for service rate, and I'm going to maximize on that, as opposed to what actually is in the best clinical interest of the member in front of me, and allowing kind of deploying of various clinician types based on that member need, within kind of payment that supports a population as opposed to an individual encounter. And so thinking about more at the population level and the holistic operations of a clinic.
Thanks, Emily. Elizabeth or Jane, do you want to add anything to that?
I was just going to say, a lot of value-based payment arrangements with behavioral health, there's just not great evidence yet for how we might implement these in a really good, in a really effective way. And I think what ultimately ties value-based payment to effective models in the literature is when incentives have specific models that they're following. So collaborative care, for example, and then they're backed by strong operational support. So if you have something that's just value-based payment in name only, and you lack either really clear measures, risk adjustment, accountability, it doesn't have necessarily the same effect as you would have when you have a very strong tied program. And then one other thing that I've heard, which I don't think there's good evidence for, but value-based payment programs, they really advantage larger organizations that have the ability to track their population, to take measurements, to do quality improvement, to spread risk. And so one of the trade-offs that can happen from adopting value-based payment in behavioral health is a predilection towards consolidation, or, you know, having bigger organizations do this really well and smaller organizations being left behind. And so those are just things to sort of monitor and try to understand, which we're still very early days in value-based payment adoption in behavioral health. And so these are just things to consider.
I wanted to add just one thing that is a little bit more sort of equity or structurally based, which is, I think, one of the difficulties of fee for service versus bundled payments, or one of the positives about bundled payments that is more about equity, is that anytime we have fee for service that's tied to licensure, we are reinforcing this incredibly hierarchical and largely inequitable workplace settings where those with licenses are considered the most valuable because they are bringing in the revenue. And so then we end up with those folks being able to have the most autonomy in their schedules and, of course, the highest pay. And the folks who are lower status and lower paid and considered unbillable or not contributing by revenue end up being over monitored and have the least autonomy and the least sort of ability to manage a work-life balance. And so I think there's another piece to it here, that value-based payments and broader payments that acknowledge the value of the team and everybody who is touching the patient can also help with this hierarchy in the workplace that isn't good for any of us.
Yeah, thank you for that, Elizabeth. And yeah, my own experience working in FQHC is everything revolving around the billing provider really set a particular tone and a culture that wasn't necessarily equitable. And when we're talking about spaces where we have very few providers, it seems like having a payment system that's going to support a team. And as I think you said, Emily, like any clinician or professional can help the patient or the member depending on what they need, instead of the entire organization revolves around the billing provider, which can be very limiting in terms of access to services. So I think this is a good segue for us to talk about burnout. And we know that this is a very serious issue, and I think sometimes it doesn't get the attention that it deserves, or it's perhaps seen as some sort of soft issue, for lack of a better way of describing it. But I would love to hear any concrete strategies that you have seen states or provider organizations use that have been successful to address burnout for behavioral health providers in the Medicaid space in particular. Anyone can jump in here.
I know I had said earlier that I was in FQ for 10 years, that I had to leave because I couldn't manage, the endless documentation. So not to harp on that too much, but I think that, and there was a question about AI that I saw in the live questions. Thank you, everybody, for dropping your questions in there. So like some of us are trying to answer them live. I know CHCS is going to keep track of them. We'll have time at the end, but I just want to say, please don't stop, because we'll make sure that people, we can speak to some of them if we're able to. But I have mixed feelings about AI, and I'm sure we could talk about that forever. But I do want to say that I think one of the best uses of AI is on administrative burden. Is that endless documentation is a service to the insurance company. It is not largely to help the patient that we're seeing. Some of it is, yes, but the great bulk of what is done is not in service to the patient. So anything that can be lifted from that with AI, I think will have a huge impact on burnout. And the other thing that I would say is the other problem I think with fee for service is because you are only making money when you have someone in front of you. A patient has to be in front of you to be making money. And that means that administrative time has to be cut to the bone. That means time spent with your colleagues to talk about patients. That means being able to block out people's schedules to have a lunch or a baby shower. Like that stuff is cut to the bone because you have to have a patient in front of you to be making money. And we're all in mission-driven organizations that we want to keep the doors open. So we're just like working patients in front of us all the time. And I think that I have a team now where we have a really high percentage of administrative time. And it's been kind of, yes, we're a small company, but it's been an experiment. How much time of connection with each other, formal connection where we're able to talk and learn together and talk about the people that we're, the clients that we're seeing, and how much informal time together where we eat together and we have dinners together. Like, how much of that time is needed? What is the dose needed to be happy and well while we're serving our clients? And so we're constantly kind of like tinkering with that. But I will tell you, it's probably 5 times higher than what I had at my community organization when I was working there. And it's probably 5 times higher than the addiction, treatment organizations I ran when I was still in Alaska. It is much higher, I think, than any of us are living with, which is we need to connect with each other. And we need to like be able to laugh and have meals with each other, and have clinical time with each other to discuss and learn.
Yeah, thanks, Elizabeth. Jane or Emily, specific strategies that you see states or provider organizations using to reduce burnout?
Yeah, one quick thing. This is a bit more anecdotal, but I think, what we hear is having clinicians feel confident in their abilities and in the services they're providing. And so I think, that's where some of our support of various training and other pieces come in, of how do we make clinicians feel confident and supported in the work they're doing, because they really want to do what's best for the members, and some of them are newer to the workforce or more junior, and don't always feel like they have the tools to do that. So supporting trainings, and one thing that's really kind of low cost that we've seen is, at least in our state, sometimes there's one agency or one organization offering trainings over here, and a lot of it is just like people don't even know what's out there. So trying to think of ways that we can connect across the state or across different entities within the Commonwealth to direct people to resources that exist to support their learning and development.
I would add on to that. So I think one of the things that they're not necessarily state level policies, but states can help support organizations on their organizational structure, their organizational policies. And that's often something that is overlooked, I think, when we talk about burnout. So when we talk to practitioners, clinicians about what their drivers of burnout are, of course, it's sort of the disconnect between their work and the outcomes, the disconnect between, what they're paid and how they're valued. Those sorts of things come up, but there's also things that like having facilities that have not been updated, having feeling insecure in their workplace environment, not having security, not being able to control their panel size and how long they see patients for. These are little things that organizations can take on, that are often ignored, not just by organizations, but also at the state and Medicaid managed care level. So these are things that I think all behavioral health organizations should be thinking about. How do we develop a culture of leadership that values our providers and hears them? How do we match the providers to the right level of care? Often in Medicaid, where we already have the most complex patients out there, the most vulnerable patients, you have people coming out of training being just dropped in this environment. And so I really do, and that's obviously cycles into burnout when you're not able to address these issues with your level of training or not having the experience. And then, I think I really like Emily's suggestions around, what their state is doing for to address burnout. But I think these are the things that we really ought to be talking about a little bit more. The final point I would make is when we talk to providers, they talk a lot about opportunities for career advancement. And so if they don't get promoted to a supervisory position, or a supervisory position is unpaid, it's additional work in addition to your clinical burden, but you don't get paid more, you don't get training to be a good supervisor, there are very limited trajectories for upward career advancement. And career advancement is something that's very important for anybody in any field to feel valued and supported in their work, and to have a long-term vision for what their job looks like in the future. If you don't have that, you don't have much. So these are things that I think we should talk about more.
Thank you so much. All such great ideas and approaches. I want to spend just a few minutes talking about technology and telehealth. So we know that this can be a helpful tool, and that there's been much more uptake since the pandemic, but we also know that it's not a silver bullet. So I'd love to hear any of you what your thoughts are on can this increase access to behavioral health care? Does it not? How are you seeing other technology solutions being used? So any reactions here, welcome.
Well,
Liz.
I'll just say that I am much more apt to see a therapist myself because I can do telehealth. So I put it off before. I would cancel and reschedule. It's like a dentist appointment where I was just like, too busy today because the driving there and the driving back. And then like you wait 7 weeks to see somebody and then you see them and it's not a good fit. And it's like you have to start all over. So I just want to say for myself, it has made a difference. I know that the evidence doesn't look like it has expanded access like we would hope. But I'll say one more thing, which is my experience since May of 2020 is that almost 50% of the clients that we see, which has been thousands of patients since 2020, almost 50% request audio only, request phone counseling. And I could have never predicted that. I've been a therapist for like 35 years, mostly in person, and then some telehealth because I'm from Alaska, and then the pandemic. But thinking it was like Zoom and video, 50% of our folks prefer a phone. I have a patient right now who says she can't really think straight even when someone's looking at her because she's self-conscious about her body. We have other people who feel like when someone's looking at them, it's like harder for them to sort of think, people who have unstable broadband, who are in rural areas of California, but they know that they can count on the landline of the phone. So I do want to say that that's just been a surprise. And we fought really hard in California to make the audio only, the telephone behavioral health benefit permanent for that reason, because of our experience. So I have a lot of hope in telephone, in specifically in the telephone, because it's not subject to the inequities of broadband access.
Emily, go ahead. I was just going to add really quickly, I think telehealth should be viewed as with any other tool. It is a tool, it is not a panacea. So it is not something that is going to solve our access problems. In fact, when we go in the claims data and we look at what happened between 2019 and 2022, there's a set of mental health clinicians that have completely gone to telehealth. So they were 100% in person, now they're 100% telehealth. And when we look at who they're serving, we actually find that they're serving people who they already were seeing, and they expand their access geographic reach by just a few kilometers. So they're not necessarily seeing new patients and not necessarily getting broader access than, but I think it is a very important tool for a very specific set of the population. I think there's a lot of opportunity there, but we have a lot to learn in terms of where the uptake is greatest, where we're lacking uptake. There's a lot of equity considerations here on telehealth adoption, and then what is appropriate, what patients prefer. So we find in the data, for example, that people with more complex mental health conditions, schizophrenia, for example, they have lower uptake of telehealth. And so some of these questions are empirically, we're still trying to study, but I think using as a tool and then thinking about how do we expand access, telehealth may not be the the only thing that we can do for that.
Yeah, I think just echoing both what Elizabeth and Jane said, I think an incredible tool that we very much support, but do not want to lose sight of, the broad needs of our members. And I think, to Jane's point, some folks that have more complex needs, telehealth isn't the best fit. And also, I think another large population is youth, and engaging with youth and families is possible via telehealth, but not always kind of the most appropriate clinically. And so making sure that we're not overly relying on that as the silver bullet to kind of solve force.
Thank you. Thank you for those answers. And, I'll just mention that I think it's so important that we don't, bring our own, like that we try to stand in the shoes of people that perhaps are looking at this differently. I remember we had a project that we led, and they were introducing behavioral health and by telehealth, and people didn't want, like, I remember someone saying that a patient had said, I don't want someone looking at my home, or like, it's too crazy in my home, like the phone is better, right? But I think it's easy for some of us to think like, well, what would be the problem with that? Doesn't everyone have Zoom? But there are lots of different circumstances that we need to allow for and accommodate if we want to actually increase access broadly. So we're coming up on 3, and I want to get to some of the questions. Thank you, everyone who's put questions in the Q&A. You can continue to do that. We're going to pick some out. And Emily, I'm going to turn to you first. So someone is asking, is Massachusetts undertaking an evaluation to measure the impact of the large loan repayment investment?
I do believe so. That program, the last few years have been really focused on getting applicants and getting funds out the door. And so I think now a lot of those rounds of funding have closed and kind of turning more to evaluation. So we don't have much to say yet, but hopefully in the coming months and years, we'll have some robust data from that initiative.
Thank you. This next question is for anyone. So the person asks, is there any evidence to date that bundled payments have improved access to care and increased salaries for the staff and clinicians at the CBHCs, I would say also CCBHCs in other states, that deliver services with bundled rates?
Maybe I can start and turn it to others. I think some of the access metrics over the last several years with redeterminations, which for reminder, there was a pausing of determining eligibility for Medicaid members during times associated with public health emergency and COVID, which made caseloads in many states go up. And then once that restarted, caseloads came down. So there was some confluence in Massachusetts of some of these behavioral health investments with caseload changes, which made some of our metrics hard to validate. But in terms of salaries, we have seen reported from provider organizations salaries increase from our investments, at least in the community behavioral health centers. And at least, we get cost reports and other things from our providers, but also anecdotally kind of really positive responses in terms of being able to increase salaries and increase retention and decrease turnover rates of those providers.
Thank you. Maybe I'll go to our next. Oh, go ahead, Jane.
I was going to say, and then there's been a few studies that have looked at the effects of value-based payment adoption, and a couple of them, they're limited, but they're robust, and they have found reductions in mental health, or increases in mental health outpatient utilization and reductions in ER utilization, for example. And then some of the more quasi-experimental approaches that have been used to study value-based payment in the Medicaid setting have been around supporting as a financial tool for a framework for supporting collaborative care models. And so in those settings, it has been positive, but the broad evidence out there is still relatively mixed.
So thank you. Someone asked a question about managed care, which I think is a very interesting topic. And this question is for anyone. And really, what role do we think managed care can play in growing and supporting the behavioral health workforce? And I'd be interested if anyone had any specific examples. I mean, obviously, we don't have to name names here, but of something that an MCO has done in the behavioral health space to help support growing the workforce, because I feel like we don't really talk about them as much, and they're a powerful lever potentially. Who wants to take this one?
I have a paper on this topic, and I've put it in the chat, I think, but I'll share it afterwards. Essentially, we talked to 27 executives across 19 Medicaid carriers, including some in the big 5 carriers, some in local plans across states. And we found that plans really have a wide range of strategies that they're many of them are trying their best to work within the constraints of the workforce shortages and geographic maldistribution. Some of the strategies that we heard about were partnering with core behavioral health providers who see large Medicaid caseloads and offering them targeted support. Some MCOs are directly funding training and supervision, so workforce expansion, workforce pipeline programs in their communities. They may offer differential payments or bonuses for high need service areas, service lines or rural areas. They are expanding telehealth in part because there are differences now. There's some credits that are given for network adequacy requirements, and where that doesn't work, mobile units, we've heard, has been a way that MCOs are using their resources to reach more remote areas. And then one thing that MCOs can do, 2 things that MCOs can do around care navigation and case management. So trying to reduce no-shows. Earlier on in the process, improving transitions between inpatient and outpatient care. Some MCOs know their providers really well. And so when there is a need in a particular area, they communicate directly with those providers by phone, or they go to site visits, which is really interesting to see. And then on the network adequacy side, developing and maintaining networks, some MCOs are focused on specific provider types. So where the need is the greatest, they try to expand contracting. And so there are single sign-on contracting where a provider says, I want to work in your Medicare Advantage or your commercial plan. And so on paper, I don't know if it's effectual in reality, but on paper, then the plan, the MCO will say, okay, well, the umbrella organization will say, well, if you're going to be participating in those products and those networks, then I need you to sign on into our Medicaid networks as well. So there are contracting strategies that some of these MCs are making. But really, these plan level efforts are really constrained by state policy, or shaped by state policy, I should say. So states often control rate setting, they control network adequacy standards, they dictate contract design and procurement. And so if there is good alignment between what the states say and what MCOs can do, then there can be a lot of, I think, beneficial experimentation, and it can be net positive for patients. But when there's conflicts, or when states don't make their expectations clear in their procurement strategies, then MCOs can't follow those rules very well, and the net benefit is less clear.
I wanted to say one thing that has to do with providing care, because I think every managed care Medicaid plan that I've ever worked with there's kind of a mantra that we don't provide care, we connect to care. Like, we're not a provider, that sort of thing. And yet they're talking to their members, they're talking to the same clients and patients all the time. They have their transitions of care, entire team. Some of them have behavioral health call centers. Some of them administrate their own behavioral health. They have case managers for people who are suffering from multiple chronic conditions, and they are talking to people all the time. So I was just talking with the leadership of a large MCO in my state, really imploring them to change their definition of clinical. I don't use the term clinical or non-clinical anymore because number one, it really just means licensed and unlicensed, billable in a fee-for-service, system and not billable. Because if clinical is defined by who influences health outcomes, then that is everyone who has contact. My doctoral research was on how receptionists in medical offices influence health outcomes, and it is significant. We know CHWs do. We know those case managers who are now trusted, who the member is repeatedly calling, and who sometimes they deliver kind of long assessments and have these long, sometimes they meet them out in the community. Instead of thinking about all these people as non-clinical, like somehow they're conveyor belts to care, they are humans, usually who are highly skilled at connecting with people. And we could, if we acknowledge that, we could provide them more tools and skills and more clinical supports so that that mental health support, that empathic behavioral health support and treatment was more embedded in every single person in the plan that members are talking to. That's what I would love to see.
It's a great point, Elizabeth, right? So extending the continuum and really much more partnership with MCOs and instead of these kind of like two siloed and like clinical and payers like working parallel but not communicating with each other could fill some gaps. Jane, I'm gonna just kind of piggyback on this question because someone asked, and I don't know if you feel like you answered this already, tell me if you did, but someone is asking like, have you found any difference in approach to workforce issues in states that carve out behavioral health care where MCOs are administering, where MCOs are in practice? So I guess, that's sort of like managed care states versus non-managed care states. Is there any research that shows different outcomes, different approach to behavioral health?
Yeah, I think the question was specifically asking about carving out behavioral health in their managed care plan. So having
Oh, I'm sorry, you're right. You're totally
behavioral health managed care versus
yes.
comprehensive managed care. And I think this is an age-old question. And surprisingly, there's very little data out there. So states are sort of operating blindly in some ways. And despite this debate, carve in, carve out, that's been happening over the course of many, many years, we're not closer to knowing like what's actually the better approach. What we've seen signals of in the literature and in the data is that carve out managed care where the behavioral health services are carved out and specialized actually tend to have more highly specialized networks of providers, and they might have the history of working very closely with local providers. They have a history of being on the ground specific for that group of people, whereas carve-in plans tend to increase utilization for people with mild to moderate mental health conditions and really using other types of providers like primary care providers more heavily. And so you can imagine there are trade-offs between carve-in and carve-out plans in terms of who is best, what populations are best addressed, what conditions are best addressed. And then obviously there is heterogeneity depending on how the MCO or the plan itself addresses these issues and their role in their community and how well they know their community.
Thank you. This is for anyone, and sort of a follow-up to what you just spoke about, Jane, and that's thinking about how we can integrate behavioral health into other areas of practice like primary care or pediatrics. I guess I want to say, what are your thoughts about that as a strategy for, as one of many strategies for increasing the behavioral health workforce? What supports are needed? Where have we seen success in having this happen? I have some thoughts, but I'm curious what you all think.
Yeah, maybe I can, or unless Elizabeth, you want to go first. Okay. I think that, I think there's a big opportunity to think about integration both ways, integration into primary care and reverse integration into behavioral health and substance use disorder spaces. In Massachusetts, we've thought a lot about supporting primary care practices in building their capacity and capability. As I mentioned, our primary care subcapitation program. We've also invested in various types of consult services to make sure that primary care physicians and also behavioral health clinicians feel supported. So we have some psychiatry and also autism and intellectual disability consulting services to acknowledge that sometimes more specialty is really needed, and that those specialists can support primary care clinicians in their supportive members. I think one though thing to consider is that often in the short term, the behavioral health workforce is somewhat fixed. And so there can be unintended consequences of if there's a lot of investment and focus put on increasing, let's say, behavioral health clinicians directly employed by primary care practices, of really shifting the workforce into that setting instead of expanding the number of clinicians or the number of practicing providers. And so I think that is just something for states to be aware of.
I would definitely underscore that when we talk about the Lay Counselor Academy and the need for just more people delivering mental health counseling, as you know, that we just can't, there's not enough clinicians, and California just did a study that it's like the shortage is way out until 2033. And is that even when we successfully hire someone, we just hired them away from another community organization. So we didn't expand access, we just traded folks, in the community. But my sort of history in California is in integrated behavioral health. I think there's a ton of evidence showing that, that there's less stigma and increased access, in many different areas. And I think it's, I used to come home, after I started working in primary care, I would come home and I would tell my husband, like, I feel like the Jedi, like all day long, I'm seeing people who would never, ever go see a therapist, like in the community. So there's something like amazing and beautiful about it, and that I think is borne out in the research. And some of what we've been talking about today in this webinar is the sort of medicalization of behavioral health, the transactional care as opposed to the relational care, the typing through sessions so that we can diagnose and do formal assessments and the person leaves and didn't actually get any help from us during that process. And I think when you put behavioral health into primary care, which is largely transactional, to the detriment of the people working in it, of course, there has to be a very concerted focus on not being absorbed into that transactional culture, and the widget culture, and a really intentional focus on preserving the relational nature of behavioral health, which is where we are able to help people, is in the relational, and ideally helping medical care change, sort of spreading the relational care outwards.
Thank you. Jane, do you want one minute to finish? Okay, so we can, that's actually really wonderful because I love focusing on relational care, and this is the key piece that we need to be supporting in all the different approaches here. So Elizabeth, Jane, Emily, thank you so much for your time and contributions. It just flew. Like I can't actually believe that we're at the end. This is such incredibly important work, and I know that our audience gained insight into what their states and providers can do to serve their members better, and how we can address the workforce, the behavioral health workforce shortage. I just want to, give a note for our listeners that CHCS is going to continue focusing on this critical behavioral health Medicaid intersection. We have this is a series that we've been doing, and we have a third webinar that will be focusing on Medicaid strategies for no wrong door in terms of substance use disorder prevention and treatment strategies. That will be later this year or perhaps early next year. We'll be sending out a date soon. But really, it was an honor to speak to all of you. I have such tremendous respect for the work that you do, and thank you so much. A recording will be sent out of this webinar to participants, and I hope everyone has a wonderful rest of their day, and be safe and be well. Take care.